Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree Chappell, managing editor and host for our podcast today. And I'm joined by Professor Monty Mythen, our editor-in-chief from London, England. Hello, Monty.
Hi, Desiree. Great to see you.
It's wonderful to see you, but I feel like it's just been so long.
I think it's a lockdown phenomenon. I'm sure we did some recording recently. It's just hard to keep track of it these days. I know you did a lot recently.
I did some recording recently.
Yeah. It's because I've been listening to them to clear them off the system. That's why I think we've done a lot of recording recently. But you've done a lot of recording recently. Well done, you.
Thank you to our editor-in-chief, Monty. Well, we have some of our other Top Med Talk friends joining us. Professor Solomon Aronson from Duke University. Hello, Saul.
Hi, Desiree. So good to see you.
It's wonderful to see you.
So looking forward to hanging out with friends and acting stupid again.
We never act stupid, Saul. And Professor Michael Grocott from the University of Southampton. Hello, Mike.
Desiree, hello. How are you?
I'm fabulous. It has been way too long since we have seen each other, though. Way too long. All right. Well, guys, we have had the opportunity to catch up today and very excited. Monty, what's on the agenda for today?
Well, a publication came out recently, which we're going to go over in some detail, which I think is very useful right at the moment because it relates to some of the risks in surgical patients who have or were diagnosed as being SARS-CoV-2 or COVID-19, as we call it, positive. Because I think we've all been wrestling as we try and reboot surgery again as to when is a safe time to perform surgery after a diagnosis of COVID-19.
Absolutely. It's a really important topic that we need to continue to look at as we go forward. You know, things are starting to open up a little bit. We'll talk about that just a moment to see where we all are personally, but kind of diving right in, Mike, why don't you're the editor-in-chief of the Perioperative Medicine Journal. Why don't you give us a quick review of the look from the paper?
I'll do that. And just remember, this is not a perioperative medicine paper, of course. It's a paper published in the journal Anesthesia this month on timing of surgery following SARS-CoV-2 infection. It's an international prospective cohort study, about 140,000 patients, of whom just over 3,000 were diagnosed as having COVID, and we can go into the detail of that because there were a variety of different means by which they made the diagnosis, and then they're divided into categories of time of diagnosis before surgery, so into 2-week intervals, so up to 2 weeks, 2 to 4 weeks, 4 to 6 weeks, and then more than 7 weeks, at least 7 weeks. And there's essentially an excess mortality, quite a substantial excess mortality when the diagnosis is soon before surgery. And when you get out to 7 or more weeks, that is similar to background. So I mean, in fact, the point estimate doesn't look quite like it's the same, but statistically it is similar to the background. So the overriding message being, if you wait 7 weeks or more, you've certainly mitigated most of the risk associated with COVID, with SARS-CoV-2 infection. And then there were some nuances around different outcomes, and overall, it's a good paper. It's interesting, and there's a reasonably strong message. But I think also a lot of places have already established their setup. So I'm actually interested to hear what everybody else is doing.
Monty, do you want to take kind of that first stab at your thoughts on this?
Yeah, well, we've been discussing this a lot, since the first time that we saw our first exposure to COVID-19. And arbitrarily at that stage, locally, led by Professor David Walker as our head for perioperative medicine, we came up with a decision to recommend that we try to wait at least 6 weeks before doing surgery. And the rationale for that was sort of general guidance about when you should proceed with elective surgery after having a viral infection, a head cold, for example, is to wait about 6 weeks. So it seemed to be pragmatic. And then in certain situations where there was deemed to be potential greater urgency for surgery, it was on a case-by-case basis. So I think now we'll nudge that out on the basis of the fact that this is a publication we have with, to inform us to the 7-week recommendation. But I think we're still going to be down to the, if there is some feeling of urgency that usually relates to a cancer diagnosis, and I'm sure we'll come back to discussing a little bit more in a moment, that it'll be on a case-by-case basis, but the general recommendation will follow the 7 weeks.
Mm-hmm. Saul, what about your thoughts, the U.S. perspective?
Well, I guess I'll just sort of echo the same sentiment. I think the question, the foundational question that we ask about any comorbid condition is, what is the optimal timing of surgery relative to the comorbid medical condition weighted against the impairment for surgery, and how do we make best decisions? I thought this paper did a really good job of parsing that out with some degree of fidelity, and gave some clarity to the step function, if you will, of risk addition, with somewhat of a plateau at around 7 weeks. So that's a benchmark that I think is important and novel, and gives some weight behind that decision, or some evidence behind the decision to ideally wait at least 7 weeks. Of course, we weigh that in the context of complex medical decisions with everything we do.
Yeah. You guys, was there anything, like any specific signals that were coming out for, specific comorbidities or any other, things that we need to think about?
I think the big message was around symptoms. So they did look particularly at respiratory complications as an example complication, and the signal was very similar to what they saw for overall mortality. But what was interesting was asymptomatic patients appear to be at a lower risk than patients who are symptomatic, and amongst the symptomatic patients, those that were symptomatic are at a lower risk to those that are currently symptomatic. So the presence of symptoms at any point, and particularly the presence of current symptoms, seems to add to the risk equation, and clearly worth putting into the decision-making process.
Yeah, I agree with that, Mike. I thought that was interesting. And active symptoms, of course, trump a history of symptoms. The one part of the equation that I wished they would have looked at is the asymptomatic patient. Many of us are carriers, and we don't know it. And so my question, and it's more of an immunologic basic science question, is what's the memory, the immunologic response to a patient who was indeed positive but never knew it? And if you test somebody, how long is the memory, the amnestic effect of the immunologic response to even characterize somebody as a positive patient, though they would not have known it because they were asymptomatic? And where does that fit in this continuum? And I think that's just one of those questions that wasn't addressed in this study.
I mean, as far as I know, all of this work is in the pipeline, all really, really important questions. And we have to remember, as we turn to the study like this, that as we get down to the smaller subsections, the numbers are getting very, very low. So we always have to be careful about power in studies. So I think it's a great job in helping us address that how long should we wait question. But I think we've got to be careful in drilling down too far in it, so it's well done from that perspective. Desiree, if I may, I just want to ask everyone the tolerance of waiting. So there's this sense in certain places, in certain healthcare situations where surgery is deemed to be scheduled, and scheduled can mean, in the context of surgery, that 3 weeks, for example. I know, Sol, that you've done quite a lot of work, I believe, in your neck of the woods to try and determine what the tolerance is of certain surgeons and certain procedures from the point of view of patient preparation about the acceptance that one can wait longer for certain cancer surgeries.
Well, it's a great point. And of course, it's answered in the context of the culture of the time and the institution. ideally, and we all strive to live in an ideal world, and rarely do we live in that world. We've been going about the business of trying to define what the optimal wait time to postpone a surgery to optimize a condition is, albeit, SARS-related infection history or other comorbid disease. Now, that's always weighted against the reality of the institutional culture and the economic external tension that exists. And to be quite frank, we've asked many surgeons to postpone elective cases because of fear of bed availabilities and ICU space, and many patients have also postponed their elective procedures as the common good and citizenship would ask. So there's, quite frankly, pent up energy and legitimate need to bring those patients into the system to operate, both because we have to pay their electric bill and because there's real patient-driven impetus to do it as much as surgeon impetus to do it. And so it's a tension between knowing what would ideally be best case scenario, and certainly papers like this help us understand that. And that's always balanced against these other societal as much as legitimate, medically driven, if you will, principles of when to behave. Now, what is the behavior right now? The behavior right now is, I want to do my case as quickly as I possibly can, damn it, because I've waited 6 months and I need to operate again. And that's equally true through the lens of the patient as much as it is through the lens of the system, as much as it is through the lens of the surgeon. And that's the reality.
And if I may, final bit, Desiree, from me, Mike, I know that you and your group have addressed this a lot because you've been involved in, fitness programs to prepare patients for cancer surgery, which has led you to sort of really take on that discussion. How long are people prepared to wait? How long can one safely wait? Do we know that?
So I think we don't know for many surgeries. It clearly, the cancer surgeries are the ones where the big concern is, and the worry being that there'll be disease progression in the intervening time, and therefore the surgery will be more challenging, and or the patient will be even more deconditioned than they currently are. And I think, so for example, our colorectal surgeons seemed relatively relaxed about that, in that they would talk about the fact there's been some small tumour there for a very long time, maybe 8 or 10 years, and another few weeks may not make that much difference, particularly if we can achieve something positive in terms of improving the likelihoods of the patient. Some other, the upper GI surgeons, much less inclined to do so on the basis that I think that they believe, probably rightly, that the tumours are more aggressive. That's obviously notwithstanding treatments that will be specifically targeted, so neoadjuvant treatments, particularly neoadjuvant chemo radiotherapy, to diminish the size of the tumour prior to surgery.
So that it's really interesting to listen to those things, because I'm practicing in Kentucky, and both of what you guys said has really applied to the practice where I am. There is that very big push to, we've missed out on a lot of cases over the last year. Let's try and make up for those. I think we're doing a lot of case by case basis. If they test positive in PAT or the 3 days before, we'll wait a specified time, which I think that time has been very difficult to define from the surgeon versus what we in anesthesia want to do. And like Saul said, there's tensions there and throughout. So, we do cardiac at our facility. And so that's been our big, we do cancer. I think some of those are pretty some of the surgeons are pretty rational about their decisions for that. Cardiac has always been a little bit more of a challenge for us to figure out who it is that we want to do this, do the case on, and who we're going to wait on. I think, again, papers like this are going to help us define it and make a case for waiting for some of the patients, which that's what I'm hopeful for, like that we just get more, more of the information behind us so that we can make informed decisions and to share that with our colleagues on both sides. So it's going to be an interesting conversation. So Monty, just lastly for you, what about you guys? Because I mean, you are working a surgical ICU, right?
Yeah, but I'm saying I think because of the local leadership and because of the requirement to pull cancer surgery together through quite a managed system, as I said, very much led by David Walker and colleagues on behalf of the North Central London Cancer Surgery Network, they addressed these issues and did their best to produce some guidance out, and everybody pretty much adhered to it because, there was a governance system that determined where patients were in the line for surgery, irrespective of the funder behind them. And I think that made it all a lot easier. Now, as I said, they pragmatically chose 6 weeks. So easy switch, I would suggest, to 7. Let's hope that the 1 week doesn't make as much difference as the paper suggests.
Yeah, absolutely. Well, any final thoughts? Like where are we going from here? What are we seeing coming down the pipeline? What should we be on the lookout for?
Well, I guess a couple of things. Just to pick up on what Monty said, my understanding of the paper, because they categorized as opposed to gave us the actual duration of time, that 7-week basket presumably includes patients out to 20 weeks. Mm. So I mean, it would seem very surprising that there's a serious cut-off there. So I think pushing it to 7, 8, 9 weeks, if you can, is probably going to be beneficial.
Well, wait as long as you can. Yeah.
Yeah. The thing we didn't talk about is what do you do? How do you evaluate someone beyond symptoms? So shortness of breath being a particular concern, and we, I guess, because it's our most common modality, we've started using exercise tests to do that. And I think if you haven't got exercise tests, then lung function and echo, because it's probably the pulmonary problems that are going to be the biggest challenge.
Well, there's the follow-up conversation, which is going to be a longer one, is as we see more long COVID patients. I think I'm in our long COVID clinic, been to it relatively recently, and there were about 2,000 patients in it when I went a few weeks ago. I believe there are 5,000 patients in it now. So there is a lot of long COVID out there. And that's a much more complicated question that's going to take, what stage during the recovery from long COVID that still has recurring signs and symptoms should you proceed with elective surgery. I think the challenges of scheduled cancer surgery is an easier decision to make because it's, your hand is forced to a certain extent. But I think the elective surgery, there's a lot to learn yet.
Yeah, Mike, I think this is a really great opportunity for you to dig deeper with respect to the things you do, which is to apply some kind of biometric or phenotypic marker to the symptom concept, because the symptom concept is vague and it's we have an epidemiologic sense of time step function, but not all time is equal. And what is the more specific marker, albeit a exercise test or some other phenotypic sign of severity of symptom that we should be tracking, is very interesting and probably will last for a long time because of the impact of this pandemic on us. And the other only closing thought I had is obviously pulmonary complications is the go-to organ that we would focus on. But we also know that a long-term sequelae of COVID has been the prothrombotic, if you will, state. Yep. And I would love for this group of investigators to do a post hoc analysis of their same data set and look at thrombotic, if you will, complications, MI, stroke, even deep venous thrombosis, yep, and see if there was some kind of gradation of outcome that they have detected as well.
Yeah. Anecdotally, we are hearing a ton of that in a lot of the different surgeries that we're doing across the board for patients that have had COVID. Well, gentlemen, any other final thoughts? All good? Did we cover it all?
We should give if I give a shout out to our sponsor, and say the exciting thing about the second episode in the series, because this is a pair. We've opportunistically leapt on this particular study to tee up our next conversation.
Yeah, absolutely. So huge shout out to Deltex. Thank you so much for the sponsorship. We are really excited about this special series. Today is just the first. Next month, we're going to be talking to a friend of Top Med Talk. We've had lots of great conversations here. Professor Mike Scott from UPenn. He is going to be joining us to talk about actually his experience with enhanced recovery, right, Monty?
Yes. So Mike was one of the early leading groups in the UK for when we had enhanced recovery before our national program, which is, they were going 10, 15 years ago, full on with enhanced recovery programs in Guildford in the United Kingdom. And they were very much sort of poster children for what we tried to achieve with our national program. Now, Mike's then relatively recently crossed the big pond and has worked at 2 centers in the USA. And I think he's going to be sharing with us his experiences of impressively rapid spread and adoption within those various healthcare systems.
Yeah, absolutely. So COVID and enhanced recovery, 2 big topics on Top Med Talk. You can always find more information on the website and more wonderful conversations there at topmedtalk.com. Gentlemen, I can't tell you how wonderful it was to at least see your wonderful faces, beautiful faces. Hopefully we will be in person sooner rather than later. Be sure to be on the lookout for new content coming out on Top Med Talk. We had some great conversations at the ERAS cardiac meeting. There's a meeting coming up, right, Monty, with the Irish.
The Irish IPOMS, you can see it on the EBPOM website, is coming up. That's a relatively short discussion, the launch of the Irish Perioperative Medicine Society. Then there's the WPOMS, which is the Welsh Perioperative Medicine Society, has a special meeting in April on anemia. And it's all building up to the London meeting, the World Congress, grandiosely called after our experience last year. Not the first time we've had a World Congress, but this one we're going fully virtual so we can reach the world, and hybrid, we hope, for the people who are allowed to gather together to consider perioperative medicine close to each other. We'll see how that goes.
Monty, I thought you were going to tell us that it was leading up to them dyeing the Chicago River green.
St. Patrick's Day. Yeah.
No, it's great. Well, and the World Congress tickets are on sale for that. So be sure to check that out. And the abstract portal is open. So we would love for you to submit an abstract, get it out there, let the world see it. We're going to anticipate lots of great conversation and all around that. So again, thanks so much for checking us out on Top Med Talk. You can always find us on, Mike.
May I be the first to wish you happy St. Patrick's Day tomorrow.
Oh, there we go.
Happy St. Patty's Day.
Beat me to it,
everyone.
Yes.
Sadly, you're not the first, Mike. I just had a message from Ross Kerridge in Australia because of the time difference. And he sent me a message in Gaelic, and his Gaelic's getting better. I won't tell you exactly what his message translates to, but it was close enough.
Well, excellent. We're all wearing green tomorrow.
That's right. Shout out to Ross. Hey, Ross. We missed you. All right, guys. Thanks so much. You can find us on your favorite social media platform, Twitter, LinkedIn, Facebook. We are there, and at topmedtalk.com. Happy St. Patty's Day.
Top Med Talk.